I just want to go over to our expert panel today. So girls, thank you so much for coming today. Very, very grateful for your time. I'm not going to introduce you, but I'm going to ask you to introduce yourself.
I'm Ray. I've been at this hospital nearly 27 years, man and boy. I knew one of the few bits of good advice my mum gave me when I was 24 was that I'd have an early menopause, which I did at 42. Straight into it, I started learning about the menopause from 25, and it's just an absolute passion of mine.
I'm Saoirse Casey. I'm a specialty doctor in occupational health and wellbeing downstairs. So I do tend to see quite a few members of staff come through our doors. 75% of women in the NHS are female, so that means that we're all either going through menopause, have been through menopause, or will go through it in the future. I'm keen to support people in the workplace as an occupational health physician.
Hi, I'm Jo. I'm a gym instructor here at Derby Centre for Health and Wellbeing, also a personal trainer. So I just really interested in how fitness and exercise can help people as they get older.
Hi, I'm Sarah. I'm a GP in Plymouth. I'm also I've been going through menopause for a while, so I'm in primary ovarian insufficiency, so I've kind of gone through it a lot earlier than I would have hoped to. And actually, I just thought, wow, this is awful. How are women suffering in this way? So I'm also doing my training with the British Menopause Society. I'm on the clinical panel for Menopause UK, which is a charity, and I'm a health inequality fellow, so I'm trying to create a Plymouth menopause network to really increase awareness around the city.
Hi, I'm Beth Newstead. I'm actually an ED consultant here at Derriford, so it's a bit bizarre that I'm here on this panel today. But I do have a bit of a side hustle in lifestyle medicine, which is the evidence base behind what we should be eating, how we should be exercising intelligently, how to manage our stress and optimise our sleep, which are all very relevant to the perimenopause and menopause. And just a quick plug for myself, I have been employed by the Trust for a day a week to offer lifestyle support for staff. So this is not something for patients, this is for staff within our organisation. So if you want me to come and talk to your team, if you want to come and have a one-to-one health consultation with me, or if you want to come and do some group sessions, which I'll be doing next January, then do get in touch. I've got a webpage on the staff net under wellbeing.
I'm Rachel, I'm a gynaecologist here. I am an HRT user, so that's probably where most of my knowledge actually has come from, and more of the exploration into that. But of course I see a lot of benign gynae. I make a lot of people menopausal when I chop their ovaries out, and hopefully I provide them with some decent HRT and menopause counselling. And the other part of what I do is paediatric and adolescent gynae, so we do obviously experience a lot of people who suffer with a premature ovarian insufficiency or failure.
And I'm Ellie, I'm also a gynaecologist here at Derriford. I look after women who bleed whilst they're on HRT and bleed after menopause, which is part of a suspected cancer pathway. But we're seeing more and more women experiencing some complications of HRT, like bleeding when they wouldn't ought to be bleeding, and so that's impacting our services, and it's enabled me to have a better grasp of menopause management and how we help women find the right HRT for them, and really understanding the bespoke nature. It isn't just a one-size-fits-all.
What I'd like to do is just start, if I may, with just a bit of talk about perimenopause. So Ellie, we'll start with you. Can you just talk us through the perimenopause, please? You know, what it is and what are some of the symptoms?
Well, if I just start by telling you what being postmenopausal is. So the medical definition of being postmenopausal is when you've had cessation of your period, so you've had no periods for 12 months or more. That officially puts you into being postmenopausal. And any time before that, and that can be really from the age of 45 onwards as a normal time, women who are experiencing menopausal symptoms, and we'll talk about those I think in one of our other questions in a minute, can be defined as a woman who is experiencing the perimenopause or is perimenopausal. So it's a term that's batted around quite a lot, it's used very frequently, but the terms we use, certainly from a medical perspective, would be you're perimenopausal if you describe any symptoms that could be attributable to the menopause and you're over the age of 45. And that would be my sort of, in a nutshell term. Now, what's difficult when we talk about cessation of periods is that many of us who are not postmenopausal in this room may have contraceptives that stop us having periods. We may have had a hysterectomy so we don't have a period. And so women think, well, how do I know when I'm postmenopausal or perimenopausal? And of course, we don't officially know when you're postmenopausal if you don't have natural periods. And so that can be really difficult, and we just have to accept that. There's no way around it. And it makes it sometimes a little bit more difficult for us doctors when we're trying to think about what HRT prescription to give women, but if we're thoughtful enough, can work our way around those problems. So I think that's why sometimes people get a bit confused. They think, well, I don't have periods, how do I know when I'm postmenopausal? Okay. But perimenopause is a better example of a word to use to describe a woman who is experiencing menopausal symptoms, and generally from the age of 45, although it can occur at much earlier ages.
So, Rachel, come to you. Can you talk us through menopause and symptoms?
Yep. So, as Ellie's has been talking about, the perimenopause is when you generally start getting symptoms. The average age of menopause is 51.6. And most menopausal symptoms will start about 4 years before your final menstrual period. But Alice just said, we don't know when that final menstrual period is. And actually, if you've got coil, then you're never going to know anyway. And those symptoms can start often, they can fluctuate in intensity, they can come and go. 1 month you might find that you're absolutely terrible, the next month you're absolutely great. And if you flick on to the next slide there, you'll see that you get this horrible effect, which is basically a hormone soup, that can cause a myriad of different symptoms. Some of them are the ones everyone talks about. Oh, you're having hot flashes. And it does seem to be the one that's most spoken about, with around 80% of people suffering with some degree of hot flashes. And then with the hot flushes, you can get the night sweats, and then you can get the insomnia. But the insomnia might not just arise from the night sweats and the hot flushes. It can arise from the anxiety and the mental health impact that you can get from the menopause. So you get this thing that happens where your periods might change. They might get a little bit longer, they might get a little bit shorter, they might get a bit heavier, they might get a bit lighter. They might stop and start and just be all over the place. And that's often one of the really obvious signs that you've got. But you're not really realising the fact that you're rumination, the fact that you're overthinking everything, the fact that you have all this anxiety, lacking confidence, self-esteem, when you used to be an amazing, confident person that could stand up in places like this without feeling any element of anxiety, which is what I get right now. And then the palpitations. So there's a whole lot of different things that you can experience that can take you down different avenues of healthcare support. So you may find you go and see a doctor because you're suffering with palpitations, but actually that can be a menopausal symptom. But before you know it, you're under cardiology. And so you can go around in circles trying to get the right help that you need, because people don't often put all of these different symptoms together and think, actually, what is the solution here? The solution is to think about the menopause and how we can help support these women through those really challenging times. The symptoms can go on for years and years. So we're not just talking about 1 year of a woman's life that's ruined. This can be decades of it, and can have some really significant other healthcare complications. So with the dry vaginas, current urinary tract infections, which women can end up in hospital with urosepsis and other problems unless you really can make the accurate diagnosis.
When I go to my GP, what am I saying? What am I asking for? And how do I get my GP to recognise what I'm experiencing and hopefully prescribe the right treatment?
So I think this has been an issue for quite a while, and if you look at a lot of the studies with the diagnosis of menopause, GPs are, we are getting better at recognising menopause, but often it was like what you were saying, Rachel, around, all of these individual symptoms. Sometimes GPs don't join the dots together so well. I think there was a study that showed that 66% of perimenopausal women went to the GP and were prescribed antidepressants as their first-line treatment instead of actually HRT, which might have actually benefited them a lot better. So the first thing I would say is absolutely, going in with the right information, going in well informed is really important. So actually going in and doing your e-consult or however you get hold of your GP and saying, I think I'm perimenopausal, actually, goes quite far instead of kind of going with the individual symptoms. And this is why actually there's a lot of misdiagnosis, especially in lower socioeconomic groups, because people who are not as educated generally are more likely to be misdiagnosed. So absolutely get on, if you have got the Balance app, which is awesome, you can chart your symptoms and go in with that information so that you can go in and say, I think I might be perimenopausal, I'm suffering from this. And one of the other difficulties that we have, I think, there's a lot of varied attitudes in general practice towards menopause. I think the other difficulty we have is in the testing of menopause. So if you're over 45, then generally we don't do an FSH, a blood test to check if you're peri or postmenopausal. We generally do a trial of HRT. The guidance at the moment is if you're between 40 and 45, the nice guidance is to consider FSH testing, but it shouldn't be a barrier to a trial of HRT. So if you're going to your GP and they're saying, oh, your blood tests are all fine, you're not perimenopausal, however you are getting a lot of the symptoms, you can go back and say, actually no, I would like to have a trial of HRT if that's the route you're going down, to see if it makes a difference. I think those are the two main things. I think also getting to know, asking a GP surgery, is there any GP that has more of an interest in menopause, is really important. And we all should be, prescribing efficiently and adequately in menopause, but there are some of us that take more of an interest in certain things than others, so just knowing who your GP is as well.
What if I don't want HRT, or what if I choose not to have HRT? What then is there for me? I'm going to hand over to Ray.
Firstly, I'm a massive advocate of HRT, having been on it for 14 years. And echoing what Sarah said, it is 60+% of women who are offered antidepressants first. And going by my own GP surgery, there is one nurse that now knows about HRT, and I've given her loads of resources, but none of the doctors, male or female, are interested at all. So things women are offered, as we said, mainly we are offered antidepressants, or if you are a chunkier broad like me, you're generally told to lose weight, because being fat apparently stops us being happy. Then clonidine, most of the things I've found are things that work on one symptom, they don't sort of work on everything, and there are 62 recognised symptoms of the menopause. So things like clonidine, which are for hot flushes, black cohosh, again, which works on lots and lots of things, but it's got phytoestrogens in it, so some people are a bit wary. There's things like CBT, which is wonderful. I mean, I'm somebody who, over the years, have accessed CBT fairly regularly, but I know that outside of the hospital, trying to get it in Plymouth, there's at least an 11-month waiting list to actually start treatment, yes, for any kind of CBT. So by then, anything could have happened. So it's a big thing if doctors say, just go and get some counselling. It's lovely and it works, but it's actually accessing it. There's things like yoga, again, that's our friend here who works here. We know that yoga works, we know that it can calm a lot of things down, it works on our mind, works on our body. There's aromatherapies, but then there's the allergy thing. There are lots of things that you need to look into, but there are very, very few things that work on a whole plethora of symptoms.
Does HRT increase the risk of breast cancer?
Overall, the bottom line is no, but you do need to have an individualised approach to every single person. You need to know all about their past medical history, their family history. You need to look at their weight, their alcohol intake, and you need to have a really sensible discussion with women about their risk. Now, as I've said before, most of my patients, I'm prescribing HRT, and I don't need to worry about this stuff. They're in their 30s, 40s, or sometimes in their teens, when actually I'm only giving them back what they had anyway. So I tell them they don't carry an increased risk of having breast cancer when they're taking HRT. And for those older women who start it perimenopausally, so it is a little bit about the age of initiation, no, there is really not a particularly significant increased risk in developing breast cancer. And you need to think about the lifestyle factors with it all. So I've got bits of paper here, like I said, brain fog, poor concentration. If you're under 60, for every 23 patients diagnosed with breast cancer every year, there is additional 3 cases, roughly, for women on estrogen-only HRT. There's an additional 3 cases in smokers, 5 cases in women who drink more than 2 units of alcohol a week. 2 units, and 10 for women who are obese.
No risk, I think.
So when you actually tell patients this and they put it into proportion and perspective, actually they're better off cutting out their alcohol, trying to lose a little bit of weight and take the HRT, because there are so many health benefits to taking it. So overall, breast cancer shouldn't be something that puts people off having a prescription of HRT. There's been a lot of fear about some of the risks associated with HRT, and a lot of that has come from some very poor studies that have been done over the last few decades, and the misinformation that comes from that, not just to the public but also to doctors. So if you look at a lot of my consultant colleagues growing up, going to medical school in the late 90s, early 2000s, that's what we got taught, and unless we actually go and seek out the new information, that's still what we think. And so you get this patient asking for HRT, and actually does it cause breast cancer, and what's the instant response? I'm not quite sure, there's too many studies, too much information out there, where do you find it, which studies are good, are you any good at interpreting the results of these studies? But overall, breast cancer risk should not be a reason for women to avoid HRT, but that isn't something that can be discussed in itself. It has to be put into with every other aspect of that woman's health, and overall comorbidities and other background risk factors. So part of my question here is, if we keep on going with the slides, I've also got, which follows on immediately, I think, about the risks and benefits of taking breast cancer. So there's a little bit of information there about actually the mortality of breast cancer, and why we're not thinking about the rest of the issues that HRT can actually have benefits for. So twice the number of women will die from cardiovascular disease than breast cancer, but we know that HRT will improve cardiovascular issues, which I'll come to in just a moment. So breast cancer, hopefully that's answered a few queries on that. But if I think about thinking about the risk of HRT, everyone's always talking about the risk of HRT, and very few people really talk about benefits of HRT, and actually, what is the risk of not taking HRT? And in 10 years' time, are people going to come back and talk to us and say, I asked for HRT and it was denied, it was declined, when actually you're in hospital with your fractured neck of femur and your osteoporosis, or you've been admitted with urosepsis with a UTI, or you've had a divorce because your vagina is so dry you can't have sex anymore. So, there's a whole load of things that we need to think about. So there are risks in not taking it. And I think that would probably be my bottom line message here, is that that's really what everyone needs to think about. There are so many benefits. So I've just mentioned vaginas. When you lose your estrogen, your labia, your flappy bits get a little bit smaller, your vagina gets a bit shorter, it gets a bit drier, you're more prone to urine infections, sex hurts, you lack your libido. So all of those things can have a massive lifestyle impact. HRT can help that significantly, whether that's just with vaginal estrogens or whether that's with your traditional forms of HRT. Obviously there's lubricants and things like that that can be beneficial, but HRT can help all of those issues. Now, if you've got someone who's generally suffering with a low hormone level, like hypothyroidism, I imagine there's a number of people in here who are hypothyroid. Did they question the prescription when they got given thyroxine? You don't, do you? But if you're low in estrogen, why do we question a prescription for estrogen? But it has become something that the population now does, is worried about, is scared about. When they did the study, the WHI study back in 2002-ish, it was really flawed. They looked at older women and women who were overweight, and they used types of HRT that I have never prescribed. So it was really, really flawed, and it led to a large amount of misunderstanding and lack of understanding of the real risk associated with taking HRT. So moving on, we've got a few more studies, we've got a few more bits of evidence, but I think pulling it all out, and I tried to pull it all into one and give you an absolute perfect summary today. I can't, because it's still just too difficult, because it's too individualised. We know that HRT absolutely, completely will help symptoms, and all those symptoms I spoke of before, a vast number of them. We absolutely know that it's good for your bones. It definitely reduces the risk of osteoporosis, osteoporotic fractures, and we also believe that it's good for your cardiovascular system. As your estrogen levels decline, we know that that can have an impact on your good cholesterol, your bad cholesterol, and your insulin resistance. And so actually by taking estrogen, you're potentially giving back those things that improve all of those factors within your circulation. And the estrogen itself is a bit like an anti-inflammatory, so it's really good on your blood vessels too. It also works on your SA node in your heart, which is why giving estrogen to someone suffering with palpitations, suddenly your palpitations can get a bit better. Other benefits, probably go back to my list again. Your brain, see, it helps your brain. I think I need to increase my HRT. Really good for brain, and we do think it's probably going to have a major impact on cognition and a reduction in the risk of Alzheimer's. How great that is, it's really difficult to tell you. I think we'll probably find that it's really significant, and I think that the impact on a brain is so relevant to probably everyone that's in this room who has a job here and wants to try and keep that job, not have to go part-time because of menopausal symptoms, but to take something that can keep you at work, because generally most of us want to be here, want to be able to function, and not just until you retire, until we die. So I'm an advocate for HRT until death.
Yes, me too.
Yes. And then your body changes as well. So we know that your lack of estrogen changes everything in your body. You get the middle-aged kind of slightly central spread. And that's about the lack of estrogen. Now, there's no evidence on whether estrogen helps to change your body shape or maintain your prior body shape, but maybe. Skin, maybe. We know that skin symptoms can be a feature of the menopause, and sometimes you put one on HRT and they say, oh, my eczema is so much better. Nails, hair. I'm sure that a lot of people who are going through the menopause will suddenly find that their glossy locks from their 20s and 30s have been replaced by something that falls apart. So you've got to think about HRT, you've got to think about the benefits alongside the risks. We mentioned breast cancer. There are absolutely other risks. People talk and are worried about the risk of DVTs, PEs, venous thromboembolic disease. And the background risk is going to be increased by taking all HRT by about 2 to 3 times. Most people don't take all HRT anymore. Most people will put it on their skin, where there's thought to be no significant increased risk at all. And stroke, same kind of thing applies. It's also about when you start it. So if you start HRT in your 60s, you've lost a window of opportunity. So you are really increasing your risk of stroke and cardiovascular disease with starting it too late on in life. But then is it because you've already got cardiovascular disease, or is it the HRT that's done it? There's so many things that make this so complicated. And then HRT itself, the risk is also side effects. Like with any medicine, you can get side effects. Ellie's alluded to one, and the big problem we've got within gynae at the moment is unscheduled bleeding on hormone replacement therapy. And often that's because the incorrect progesterone is being given. Just 2 tiny little tweaks of the progesterone can get women onto a preparation of HRT that doesn't cause these horrific referrals in as a query cancer through to see somebody like Ellie. So you do get side effects with HRT, and you do need to understand that.
Beth, if I can come to you, please. How important then is lifestyle in managing symptoms?
So I think lifestyle's important in every aspect of health, actually, but I think it really can come into its own during sort of perimenopausal and menopausal phase. I think the other thing to say is it isn't magic. You can't expect to make lifestyle changes and for all your menopausal symptoms to go away, just like HRT isn't always magic for everyone, or I personally think it's a little bit magic. There's limited time to talk today, so I thought I'd just pick out a few key points. So from a nutrition perspective, I think is a real opportunity when you hit the perimenopausal phase of life to make some changes to your diet. Up until the perimenopause, we're in a much better position than men from a metabolic point of view, but unfortunately it all goes steeply downhill at that phase of life, and our glucose control can often go out the window, and we tend, as Rachel said, to become much more insulin resistant. So some really simple things that you can do are to eat more plants. So I'm a real advocate. It's not the 5 a day anymore. That's, say, last decade. We should all be eating 30 plants a week. So that's fruits, vegetables, nuts, seeds, whole grains, herbs, spices. You can even count some good quality coffee and dark chocolate, which is awesome. And so, just challenge yourselves to have a think about how many plants a week you might be eating. And the rules are that you can only count each thing once a week. So if you were to have an apple a day, sadly that only counts as one portion. So it's harder than you think. The good news is that different colours and varieties of things can be counted separately. So if you were to have a portion of red pepper, yellow pepper and green pepper, you could count that as 3. And it's probably all about increasing your fibre content and feeding the gut microbiome that are all resident in your distal colons. And we're thought that that's probably going to be a lot of the science is suggesting that a healthy gut microbiome is linked to much better metabolic control. The other big thing that you can do is cut out ultra-processed food. There's been a lot in the press about that recently. Unfortunately, it's ubiquitous. We're being set up to fail everywhere we go. There is ultra-processed food. It's not a criticism of anybody. We are desperately being set up as a society to fail on this. But just have a little think about what you're putting in your shopping baskets. I always challenge people to have a look at the back of the packet, and if there's an ingredient on there that you don't recognise or that you wouldn't use to cook in your home kitchen, it's by definition ultra-processed. And sadly, things like almost every cereal you can buy, every loaf of bread from the supermarket, fruit, yogurts are all ultra-processed when you actually go digging, so it's harder than you think. A third thing that you think about doing is just not eating for 16 hours of every day. It's a good idea to give your gut at least a 12-hour period where it's not eating or drinking anything other than water or black tea or coffee. And I'm happy to speak to people individually about some of the science behind that. I think you're going to talk a bit about exercise, aren't you?
Yeah.
So I won't steal your thunder, but I will just say, even if you've never exercised before, it would be a good time of life to start doing it. It doesn't have to be running marathons or doing Ironmans. It can just be a little bit more activity. I'm a big fan of just short, sharp bursts of movement during the day. Call them movement snacks. If you want to do some cardiovascular exercise, then interval training is a really efficient and quick way of doing it. But my big passion is that all perimenopausal men, menopausal women should be strength training. Building muscle helps with our blood sugar control, and obviously load-bearing exercise is going to help prevent osteoporosis, which we've already talked a little bit about. It doesn't have to be lifting big weights in the gym, although I'm a big fan of that as well. It can be sort of bodyweight exercise, resistance bands. It can be something that you could fit in very easily to a home routine. It doesn't have to be done at a gym. But I will hand that over to you in a second. And just finally, sleep. So when they look at menopausal and perimenopausal symptoms in questionnaires, sleep is often the biggest thing for women, and I can see lots of people nodding around the room. In fact, that was the first clue that I was perimenopausal. I'd always slept like a queen, and suddenly I was awake in the early hours of the morning feeling anxious about ridiculous things. So if you've never had a good sleep hygiene regime, then again, this is the time to do it. I won't teach you to suck eggs, it's mostly common sense stuff. But keeping your tech out of the bedroom. Bedroom should be for the two S's only, sleep and sex. Make it a haven. It should be cool, it should be dark, it should be noise-free. And the single biggest thing that you can do, and I really appreciate that this is hard to do as a shift worker, is to have a predictable going to sleep time and wake up time. And I'm a shift worker, so I get that that's hard, but if there's any way that you can incorporate that into your regime, even at the weekends, then that is been shown to be of great benefit. What else can I tell you about sleep? There is some evidence, it's not fabulous evidence, but in terms of being really sort of high quality randomised controlled stuff and trial stuff, but there is some evidence that magnesium glycinate helps some women to sleep a little bit better. And I know that it's helped some of my friends and colleagues. So it's unlikely to do you any harm. We're probably all magnesium deficient in the room anyway. So if you wanted to give that a try, that would be a very reasonable thing to do.
And Jo, I want to come to you, please, and just if you could just give us a bit of insight in terms of exercise. What are the kind of exercises we should be doing? Beth's already touched on it, but if you could give us some more detail, please.
I think definitely I agree with Beth in terms of strength training. I think as we age, I think we're working against sarcopenia, which is losing muscle. So we have to work harder, I think, at this stage of life to maintain what we've got in terms of muscle, and also there's no reason why you can't get stronger and fitter than you've ever been as well. So I totally agree with that. And then it also, sorry, is it Rachel? Yeah, sorry, Rachel was saying when she was mentioning the benefits of HRT, and I was just thinking, gosh, you know what, that's also the benefits of exercise. Like, so you can sort of, if you're taking HRT and you're exercising, you can sort of double your money, can't you? You can really go to town. You've got so many benefits going on, because exercise is just good for mental health, physical fitness, health and well-being. It's just, for me, it's been my saviour, HRT and exercise as well. So I'm a fitness expert, so I'm going to advocate it, but I really do think that if you can somehow fit in an exercise schedule into your life, even if it's exercise snacks, as you said, you're gonna definitely see some benefits in terms of your physical and mental well-being. So I would just say that would be one of the things I would say, to treat that as your self-care, to sort of get that into your day somehow. I think that would just be an amazing thing for you to do for yourself. And then just thinking about, so that's sort of overall exercise benefits, but the importance of a strong body. And I think when we're talking about pelvic floor exercises as well, thinking about maybe where to start could be thinking about a strong core. So if I could just, if you could all just think about for a minute for your posture. So your head and neck are in alignment, the top of your head to the ceiling, shoulders rolled back and down. And if you just take a nice deep breath in and feel your ribs expand, and then as you breathe out, just gently pull your belly button to your spine. So you're nice and upright, pulling your belly button to your spine. So now what you're doing is you're engaging your core. So that's one of the most important things to start off, I think, with exercise, is to think about that core engagement. And then that also leads on then to more of an awareness of your body, an awareness of your core. And then you can start to think about pelvic floor health and how the exercise of your pelvic floor can benefit you, because as with all the muscles in the body, those are going to weaken as we age as well, and other stresses on your bodies, sort of high impact exercise, childbirth, being a bit overweight can all stress the pelvic floor area. And Vicky is our expert on pelvic floor health and exercises as well, so she'll be able to help you. But I just think as a general thing, if you start to think about an awareness of your core, really think about building that awareness into your everyday life when you're sitting down, and then other activities that you might do, just engage in your core. So you might just do that little exercise now and then think about that later on in the day. Think about your posture and engagement, and then maybe do some of the pelvic floor exercises, which is where you might sort of pull it up and in. So your pelvic floor will be pulled, so your belly button is pulled into your spine, and then there's a pulling up and in of your pelvic floor as well, and you just hold that for 2 and then release for 2, and then you can gradually build up over time as you feel that becomes stronger and your core becomes stronger. And then after that you can then build that into your core exercises as well. So there's lots of core exercises we can do, and I might go through a few of those if anyone wants to join me.
Adding to what was being spoken about, your core and your pelvic floor. And yes, we want our pelvic floor to help support us with all our exercises, but I've had quite a few of you come up to me today with symptoms of urinary incontinence or urgency, prolapse symptoms, which if you're doing your pelvic floor exercises correctly, can hopefully help to actually ease some of those symptoms or totally eradicate them. I brought this up with me because in my clinic, when I talk to women about pelvic floor exercises, one of the first things I do is I show them a model of the pelvis and the amount of eyebrows that go up, because they have no idea of where their pelvic floor is or how big it is. So this is a slightly smaller human pelvis, but everything in red is your pelvic floor. So it's covering the whole of your base of your pelvis. They're your sit bones. If you wiggle in your chair and you feel the bony bits in your bottom, they're your sit bones. That's that bony bit at the front that you can feel. There's your tailbone. Your pelvic floor covers all that area. So a lot of people in their lifetime have been told, do your pelvic floors, but they never really quite know where it is. That's where it is. All right? It is more or less the size of your two cupped hands. It's got a couple of really important jobs to do. Your pelvic organs are sitting in here. You've got your bowel, you've got your uterus, and you've got your bladder. So your pelvic floor is helping to support those, and if those organs are being supported, they're going to do their job better for you. The other important thing about the pelvic floor is it wraps around the openings, your back passage, your vagina, and then your wee tube, your urethra is just at the front here. Some of the muscles in the pelvic floor are wrapping around those, helping to keep those closed when they should be closed, and only relaxing and emptying when you're in that safe place of your toilet. So if you've got a good, strong pelvic floor doing its job, you shouldn't be feeling prolapse symptoms, you shouldn't be leaking wee or poo, or having that urgency. So how do we keep these muscles nice and strong? Pelvic floor exercises, which we've already talked about, but a nice easy way to think about engaging this muscle is to think stop a fart, stop a wee. I'm doing that with my hand because I can't stop myself from doing that with my hand when I talk about pelvic floors, because we're wanting to squeeze around this sort of back area here, yeah, right round your back passage. If you can just home in on that now whilst you're sitting there and just think, what would I do to try and stop a fart? Yeah, and hopefully a lot of you are feeling that little squeeze around your back passage. That's you starting to engage with your pelvic floor. Another nice cue, don't try this at home, but think of a marble right at the entrance of your back passage. Just think about it, don't do it. And imagine lifting that marble up into your bottom, and that gets a nice squeeze going as well. Okay? The pelvic floor, yeah, you're all doing it, good. The pelvic floor then lifts right up to the front. That's where we're going to get the support onto the bladder by getting the lift of the muscle to the front. Lots of people can get that if they think stop a wee. So if you're thinking stop a fart, stop a wee, that starts to get that squeeze lift. Or lifting the marble into your bottom and lifting the marble to the front. Okay, squeeze, lift. You need to make sure everything else is nice and relaxed, nothing else should be moving. I don't want you squeezing your glutes, don't want you pulling in on your tummy too much. Don't hold your breath, this should all be done with a nice relaxed breath as well. Talked about engaging your tummy muscle as well. That is, we do want a little bit of tummy engagement when you do your pelvic floor exercises. That's a good thing. That's only the other thing that should really be moving when you do your pelvic floor. Yeah, so if you stop a fart, stop a wee, can you squeeze out, and can you feel that you've let it go as well? It's really important to feel the squeeze and to recognise when you're letting it go. If you can do that, you can start building exercises. And when you're doing your pelvic floors, what we encourage is trying to do some quick pulses with your pelvic floor and also doing some endurance holds. Different muscle fibres in all our muscles, and we want them to be able to respond quickly. So when you cough and sneeze and you're wanting them to work quickly for you, they're there. But also your pelvic floor needs to be working for you all day long, so you want to practice some endurance holds. So if you can try and build up towards trying to do something like 10 quick squeezes and then 10 long holds, where you gradually over the weeks build up that you can hold for longer, up to about 10 seconds. So 10 reps of 10-second endurance holds, 10 fast ones. You can do that a couple of times a day. Hopefully, if you've got any pelvic floor issues, symptoms, they will start easing. That's a real quick run through, if that's all right. If you have any issues, there is a self-referral form on the hospital website, and you can refer yourself to physiotherapy, and we can chat more and do individual tests.
Minerals, supplements, is it worth it? Because they cost a fortune. I mean, Holland and Barrett,
Yeah.
you can spend a load of money in there in one go. Is it worth it?
I am a big advocate as an adjunct to HRT. When I worked in MS research, the fantastic consultant that I worked with would put all his patients on D3. And other doctors, especially GPs, always say it just makes you weak, expensive. Now nearly every person that comes through the discharge lounge is on D3. Nearly every woman over a certain age is on B12 or B6. And these, along with magnesium glycinate, are my sort of go-tos. So I recommend that everybody should be on a D3 with a K2, so it helps it metabolize, B12 and 6, and magnesium glycinate, because we are pretty much all deficient in it. There are lots of things that work. When I first went was perimenopausal. There was only really oral HRT preparations, which were synthetic, unlike the skin ones now, which are predominantly natural hormones, body identical hormones. But so there are you need to get the real ones, and I did some study with Anita Rolfe, who's a medical herbalist in this country, and she has got a website. She has her own range of vitamins and minerals as well. And there are things that you can use. There's sage leaf, there's black cohosh, there's St John's wort is good, but that is one that can have a lot of interactions, not with drugs, but it can have quite a few side effects. But like I said, it's knowing your stuff, going to the right people. Holland and Barrett, luckily, are predominantly trained in what they do, so don't just go sort of ad hoc willy-nilly from Amazon. And the body will absorb what it needs to absorb. And, you know, I think, like I said, in 15 years that I've been taking D3, the fact that now Big Pharma has got hold of it and has given it a posh name, which is, you know, they can't call it D3, they've got to call it something else so that the hospital can give it out, same as B12. Yeah, it's those would be my 4 to go to, but there are other things, and I think that as an add-on, as I said, to HRT, I think they're very good.
No, that's useful. So B12, B6, D3 with the K2
Yeah.
And magnesium as well. And the website that we're looking for is Anita Rolfe.
Ralph. Yeah.
Ralph, is
Ralph.
it?
It's
R-A-L-P-H?
It's just R-A-L-F.
Okay. R-A-L-F.
Yes.
Okay, so
And she's
Anita
British.
Ralph, R-A-L-F. And I suppose the other bit is, and I wouldn't be a good pharmacist if I didn't say, but if you're taking any homeopathic remedy, just make sure that they don't interact,
Yeah.
like Ray says,
Yeah.
with your other medication.
Another one that I've used for years, and I've recommended it to other people, and this will, whether you're going through PMS or perimenopause, it will stop you eating your children and killing your husband, because 3 weeks of the month you might be fine, and then 1 week of the month you actually are homicidal. And it's called Agnus castus, and it's a cacti, and it's very good, and it helps with bloat. And I had random periods from when I started at 12, and I started on that, crikey, like 25 years ago. And I would come on a Wednesday, finish on a Friday. I didn't have bloat, I didn't have cravings, I didn't want to kill anybody. It might have been cheaper than divorce, and I've recommended it to lots of people, and it has saved their marriages.
Is it natural?
It's natural, perfectly natural.
So Ellie kicked us off on this knowledge journey. What age can I stop taking contraception?
So there are quite clear rules. So if you are under the age of 50, you need to have had no natural periods for 2 years before you can be confident that you won't conceive unexpectedly. So if you're under the age of 50, you need to have 2 years without a period before you can stop using contraception. If you are over the age of 50, then that's 1 year, 12 months of no periods before you can stop using contraception. But for many of us, we use contraception that stops our periods. So how do we know? Okay. So we often don't know. And as you transition from a reproductive age, contraceptive using woman, if that's who you are, into the perimenopause, it may be that you need to add in HRT to your contraception. So for many women, and some women in this room may already be on contraception and HRT, we use them, we align them together in a transition. When you get to 55, you don't need contraception after the age of 55. So 55 is the upper cut-off. Okay? But we will see women who are in their early 50s usually unexpectedly getting pregnant. So it is an absolute thing. It is quite unusual, but it is a thing. Okay? I think I was at a meeting last week that said there were 20 women in the UK that had a termination of pregnancy over the age of 50 last year. So it's a thing. And certainly during COVID, where women who were older, who felt they probably didn't need HRT anymore, and they didn't want to bother anybody to get HRT because they didn't want to bother anyone because of the COVID outbreak, so they stopped using contraception and they were pregnant. And so we were finding the women requesting abortion care during COVID were actually older women rather than the teenagers getting drunk and mistakenly get pregnant. So that's all gone back now. It's teenagers again, which is absolutely fine. So there's some rules, and then there's the blurry bit where you are in the mix of your perimenopause requiring contraception, because HRT, standard HRT, is not contraceptive. So for many women who are in this transition and requiring contraception, we'll use the Mirena, which is a hormone contraceptive device that sits in the womb. Sometimes people call it a hormone coil, but there's nothing coily about it. It's a device that's in the womb. And we use that as a component of HRT. And we haven't really touched on what HRT is. A HRT for women who have a womb needs to be estrogen and progesterone, and it's the estrogen bit that helps with the symptom, the soup of menopausal symptoms, and it's the progesterone component of the HRT that generally prevents unexpected and unwanted bleeding. Okay, so you have to have the progesterone component in your HRT if you have a womb, otherwise you will just find yourself in my clinic because you've been bleeding, and your womb may be at risk of developing an overgrowth and thickening and potentially cancerous change if you don't have progesterone to protect it. And so, on the whole, the safest type of hormonal contraception to use when you're in the perimenopause is progesterone-based contraception, and the Mirena is licensed for use to protect the womb against the estrogen effects used in HRT, if that makes sense. But you can also have the progesterone-only pill on top of contraception, and that's totally fine. So if your GP is giving you like 2 lots of progesterone, because you're on an estrogen patch and a progesterone tablet called Ertigestan, or one of the other one that I can never remember. There's a new word. Glipotex.
Tell us.
I'm not a
Progestins,
so look at Anna.
And you might find that you've been asked to use the progesterone pill on top of that for absolute assurance that you won't conceive.
Because I want to very quickly come to Sarah and talk about the impact of health inequalities on the menopause.
In terms of health inequality, it's quite a complex topic because, even between, I think Plymouth is one of the worst actually in terms of male and female health inequalities.
Really?
So women in Plymouth will live the last, on average, 26 years of their life in poor health, compared to men who live the last 13 years of their life in poor health, and that's very, that's actually quite an anomaly compared to the other countries, other cities around England. So there's a health inequality there with men and women, and I do think there's been quite a movement in terms of the next step really in women's rights is around menopause, because actually what we see is that at this stage in a lot of women's lives, this is when women are really, really stressed, are often coming to the peak of their careers. They've got elderly parents sometimes to look after. Their demands on them are really, really increased. And then they go through menopause. And so actually the impact on society is quite significant. And I think if this was happening to men, it might have been a different story, just because of the nature of history. And, I think the first female doctor was only in 1870 or something. So we're kind of a bit late on, really. There are other health inequalities, though, around menopause and how we experience menopause as well. And this is something I'm kind of quite passionate about, because there is evidence to say that if you are from a poorer area, that your menopausal symptoms will be more severe, and you'll go through menopause slightly earlier than if you're from a more affluent area. Also, you're more likely to get misdiagnosed as having fibromyalgia or depression if you're from a less affluent area. And these are the population groups that are high risk for cardiovascular disease and diabetes generally. And so actually the potential benefit for addressing their menopause adequately and preventing cardiovascular disease and type 2 diabetes is quite significant in those populations. The other massive health inequality around menopause is between white Caucasian women and people of colour. And I think, just looking around the room when I came in, Derriford is the biggest employer of people of colour in Plymouth. And actually looking around the room, we look and see how many how much information is kind of getting to people of colour and how many women are coming forward, and there's a massive discrepancy. And again, you know, people of colour, if you're Southeast Asian, your risk of diabetes is twice that as if you're white, and again, your risk of cardiovascular disease is 3 times. So actually, again, it's the, you know, there's a big potential of preventative medicine during this menopausal time for certain populations. So what I would like to say to you all is, you know, when you go back to wherever you work, you know, if there are people of colour that you work with, you know, it's really valuable to start talking about this, because often it will only be through work or, you know, through a connection at work that this starts getting talked about. And the presentation in people of colour is generally very different to people that are white. So first of all, we know that you know, African women, and mainly African women, will go through menopause 3 years earlier on average than white women. So the figures, the numbers that we're quoting are all for white Caucasian women. Also, you know, if you're South Asian or Asian, the primary complaint that you'll have is, and I see it with some ladies that come to me as well, is they come in and they'll say, "Doctor, my body just hurts all over," you know, and that would be the main thing, would be the joint pain rather than the hot flushes and the night sweats. So we have to start, I think, really creating this awareness, not just for us, but also transforming, you know, how we have faced health inequality as women, and using that to actually transform and have a positive impact on the other populations that are facing health inequality, and looking at ourselves and saying, what can we do actually to, you know, to really further this movement and get this information to people that might not be that aware.
I'm going to ask Sasha this: what support is available for us at UHP to help us with the menopause, please?
Okay, well, obviously I work in occupational health and well-being downstairs, but most of the staff who are going through menopausal symptoms shouldn't really have to come as far as occupational health for support, because there's a lot of steps you can go through before you get to that stage, although we are here to help when required. But the first port of call, and I often refer people to, when you think that, you know, a huge proportion of people, for example, that I might see as an occupational health physician, will be women between the ages of 40 and 60. And I'm always aware, and I always think menopause as well, because no matter what somebody turns up with, there's usually an element of menopause, as you can tell from all the symptoms. 62, you know, so that's something I'm always aware of. But even if it's something very straightforward that somebody's come to see fitness for work post-operatively or something like that, you know, I'll still signpost them to the wonderful SharePoint on menopause curated by Jen. There's a lot of information on there, lots of resources, and an absolute key thing which is available to all NHS staff is, I know we're had it up to here with mandatory training and so on, so try not to think of it as e-learning, but there is an e-learning module called Menopause Awareness for NHS staff, and it is absolutely excellent. And don't think of it as e-learning for work, think of it as information to empower you, you know, sort of E for empowerment rather than E for e-learning. And there is so much there that in that module, or you know, that I think everybody can learn a lot from it. And I know it's something that's we've discussed many times in the Women's Network, and we've often talked about, you know, whether or not that should be part of mandatory training, because we're all working with people who are menopausal, and 75% of us, of NHS staff, are women. Either, as I said before, if you're not going through it, you will one day, or you will have done, you know, so it's a benefit to all. Those things aside, your first line of support will be your line manager or another manager. If you feel you can't talk to your manager, maybe somebody else in the department might be more approachable, or you might feel more approachable. But, you know, like Darash and I were talking earlier, we must not feel that we're different if we're experiencing menopausal symptoms, because we're not the different ones, we're the majority, you know, so let that thought empower you whenever you're asking for help with menopause. But, you know, for most things, it's fairly obvious what you need. If you're overheating in a tight-fitting, uncomfortable uniform, it's not rocket science to think, well, maybe my staff member would benefit from a lighter uniform or wear scrub tops, you know, particularly if they're bathing patients and steamy bathrooms and things like that, you know. And it's something very simple, and it's not expensive to take these measures, you know. Things like if people aren't sleeping well at night, maybe they need to have later starts to their shifts, or, you know, work shorter shifts over more days rather than 3 long days. And I mean, it always surprises me how, when I was a junior doctor many moons ago, you know, generally nursing staff, for example, worked earlies or lates or nights. And now it's long days for everybody nearly, and it's very rare that we have people working an early shift or a late shift. And you know, sometimes that's not the best thing for people's health and well-being, I think. But that aside, short breaks if people are overwhelmed, hot flushes and things like that, just need some time out just to calm down and cool down. Sometimes maybe a risk assessment needs to be done if somebody is really struggling with menopausal symptoms and really struggling with heat and so on. And sometimes some departments, maybe the ventilation isn't as good, or, you know, I think managers can just listen and understand, and they will probably be able to do an awful lot before you even have to think about occupational health, really. We also have our wellbeing team with Jen and others, and you know, and the Freedom to Speak Up guardians. So if people aren't feeling supported by their management team, you know, do speak to the wellbeing team or the Speak Up guardians, and just to get a little bit of extra support. In occupational health, we also have an excellent counselling team, and sometimes that can be necessary as well, with all the mental health issues associated with the menopausal era. And sometimes a single session therapy can be just enough to help people get back on track with that as well. Important to remember, as an occupational health doctor, we always talk about the Equality Act. So the Equality Act 2010 doesn't specifically cover menopause, but menopause is related to 3 protected characteristics of the Equality Act: age, sex, and disability. So it is likely that when you take everything into consideration, the Equality Act will protect someone with menopausal issues against discrimination and so on. And I think it's really, really important because, you know, I mean, we didn't mention this, I don't think, earlier, but, you know, 1 in 4 women think about giving up work because of menopausal symptoms, and 1 in 10 women do give up their jobs because of menopausal symptoms. And in occupational health, it's our duty to try and retain staff, and we're working for the staff member, but we're also working for the trust as well. We don't want to lose experienced staff. We don't want to lose that wealth of knowledge. And, you know, women who've worked in the NHS for all those years have so much to give, and, you know, we need to harness that and support as much as we can. So I hope that we will have more lines and avenues of support in the future with a menopause policy soon, hopefully, and maybe other things. So watch the space.
No, thank you.
A lot of GPs that are ill-informed or uninformed will say you can only go on it for 3 years. HRT, you can only go on it for 5 years. There is no limit to how long you can stay on it, and I will be on it for life because nobody needs me off it. So if your doctor says once you're over 55 you don't need it, once you're over 60 you don't need it, or you can only go up for 3 years, it is a load of poop unless it has actually made you ill.
Oh. Thank you very much.
Just caveat that a little bit, because I just think,
Oh,
I think there is from a medical perspective, there would be a risk benefit about what are the benefits of staying on HRT at this stage. So if you're 75, 80, your risk of thrombosis will increase, and you may not be getting significant preventative benefits in an older age group. So if you're on really whoppingly high estrogen doses,
when you're 70 or 80, that probably is not okay, and actually we don't have the research to tell us about the safety of high estrogen. So I think there's just a small caveat to say, take it to your grave, but in small doses.
Yes, actually, I think as a team we should have T-shirts that say "Stop a fart, stop a wig." Or is that just me?
I was going
In pink.
to,
With glitter.